Good morning, good afternoon. Welcome to our fourth online forum, our maintrac online forum for this year. It is Breast Cancer Awareness Month, so the topic will be breast cancer therapy and how we can use maintrac to support breast cancer therapy. Welcome, Professor Katharina Pachmann, the founder and chief scientist of the maintrac system. She is as keen as ever to push the boundaries of what we can do and what we can offer, with a focus of to do the best thing for the patient, which is in front of us. Breast cancer is a particular big issue, and Professor Pachmann will be talking about that. So without further ado, Professor Pachmann has some slides to present and some great information, and we'll have some time to discuss. So over to you. Thank you.
Thank you, Dr. Flora, for introducing me. And as you mentioned, we have the Breast Cancer Awareness Month, and that's why we thought it would be helpful to show how maintrac can be used to support breast cancer therapy. As we all know, metastases form from circulating tumor cells. 90% of carcinomas are of epithelial origin, and carcinomas disseminate or release cancer cells, and we call them circulating epithelial tumor cells. We present here the maintrac approach, which is a minimally invasive procedure that allows detection of living circulating tumor cells, and it can be subsumed under maintrac biopsy. What we can help you in the therapy of your patients with is, first of all, counting the cells, the tumor cells in blood. And here it's important not to have one single number, but the trajectory of the cell numbers over time. We also can, in advance to therapies, test the therapeutic substances, and then you can choose the most effective one. And as we know, therapy and tumor cells can change over the time of disease, and then it's important to know whether the cells still have the therapy relevant characteristics at the primary tumor. And last not least, we can also test for the aggressiveness of the tumor by testing the tumor sphere formation with the help of stemtrac. As I mentioned, it can be subsumed to liquid biopsy, and it's a minimally invasive procedure which allows the detection of living circulating tumor cells. How do we proceed? We look for cells that differ from the blood cells by using an antibody that is directed against an antigen that is present on the epithelial cells and not on blood cells, which is EpCAM antigen. And the antibody is fluorochrome conjugated, and that way we can detect the circulating epithelial tumor cells. It's highly sensitive without any enrichment steps. It can be used for all solid tumors. It's fast and reproducible, and it's performed in a DIN ISO certified laboratory. Here is the workflow, how we proceed with when the samples arrive. First of all, the red blood cells need to be lysed because they are 1,000-fold more than the white blood cells. And then the sample is spun down, and the tiny little sediment down there are the white cells containing the tumor cells. The cells are then fluorochrome labeled with the anti-EpCAM antibody. the suspension transferred into a 96 well plate. And we have this special microscope, the scan-R, which scans all the wells and detects living cells, which are displayed in 0.7. And then we can draw a trajectory of the number of cells over time. Here, once more, the differentiation and gallery of one single patient with the living cells on the right upside. We have to look for a nucleus, a nice nucleus visible. Then there are cells which are already in the process of dying or have died and have lost their DNA. That's the middle gallery. And the lowest gallery is the cells that have a permeable membrane so that a red stain, the propydium iodide, can enter the cells, and the red nucleus signifies that this is a cell in the dying process. For evaluation, we only use the living cells on the right side. So I would like to show for first the therapeutic substance testing. For this purpose, we use the cells and expose the living cells and expose them to the therapeutic substances in the concentration which you later want to use in your patient. And then we can show whether these cells are killed, response, or not, non-response of these substances. They need to be cytotoxic, not only cytostatic, because we can only test for toxic substances. We can test different concentration of the substances, and we can also test combinations, and we can also test hypothermia with or without the respective substances. Here you can see the time-lapse analysis of cells, and you can see that in the upper gallery there is one cell which does not have any influence. It's not dying during the time it has been observed, and this is under control conditions. And you can see that with different substances, there is a different dying process in these cells. The dying process is signified by the increasing red staining of the nucleus. We present, or we inform you of the sensitivity of the cells by the percentage of dying cells at certain concentrations. And here you can see that the taxanes are the most effective ones and others are less effective. The interpretation is if it's less than 10%, no dying cells, this drug is ineffective. If it's between 10 and 50%, we call it marginal efficiency. And everything above 50% is good efficacy. So as previously mentioned, also the properties, the characteristics of the tumor cells can change during the course of disease. And that's why it may be important to test for therapy-relevant tumor characteristics during the course of disease. What can we do? Yeah, since some of the therapies are only useful if the tumor cells exhibit the respective characteristics. This can provide additional information about, on one hand, the aggressiveness of the tumor, or the possibility to respond to a potential targeted therapy. And the surface characteristic and the genetic characteristics of the tumor can also change during the course of disease. And this can influence the effectiveness of applied therapies like, for example, hormonal therapy. So this is an example how, for example, the estrogen receptor can be tested in addition on these EpCAM circulating cells. And on the right side, there is an example how the amplification of the HER2 new gene can vary in the cells during therapy. So we can look whether there are only one or two genetic parts of the HER2 gene, or whether it's amplified, and these cells are more responsive to growth factors. The additional test which we can perform on the circulating cells is stemtrac. And with this approach, we grow only those cells which have a potential to divide, and these are called circulating cancer stem cells. The circulating cancer stem cells are most probably responsible for recurrence and for metastasis, because for metastasis to grow, it's really important that the tumor cells are able to expand and to divide. And these cells mainly are resistant to many chemo and radiotherapies, and this makes it so ineffective, some of the treatments which destroy or which reduce the initial tumor. And on following the determination of the cancer stem cells, we can, for the first time, develop strategies to eliminate the cancer stem cells. How do we proceed to grow these cancer stem cells? We do the same as we did for analyzing the circulating epithelial cells, but then we culture these cells from the sediment in culture tubes together with the white blood cells. And in this instance, some of the cells can start dividing and form these tumor spheres. We do not shake the tubes because it's very important that the cells remain at the same position and that we only detect cells that have been dividing and growing into these spheres. This is typical for cancer stem cells. What do they look like? They grow over time. In most cases, we have them growing until day 21 because then they are very well visible. And we stain them with anti-EpCAM to be sure that these newly formed spheres are EpCAM derived or epithelial derived. Subjects, we have so far not seen any such tumor spheres. And we also can stain them for additional markers which have been shown to be typical for stem cells. And this is a low CD24 expression, a high CD44 expression, and these cells express LDH1 activity, which can stain the cells into green fluorescing cells.